to our session this morning. It's our the OCDPA's second panel discussion event, and as you can see, it's entitled Reducing High-Risk Alcohol Consumption, Where is the Action to Match the Evidence? And we're joined today by almost 200 participants from across the province and even from across the country. We have several participants from outside of Ontario joining us this morning. And our participants include those from public health, from community health centres, a range of not-for-profits, health associations, Public Health Agency of Canada, and a variety of our own OCDPA members. So a very warm welcome. And I also want to just take a moment to thank our two co-hosts. This event was organized and brought to you with a collaborative effort between the Centre for Addiction and Mental Health and with Public Health Ontario. So thank you so much to those two organizations for pulling this event together for us. OCDPA is a collective voice here in Ontario on chronic disease prevention, and we represent 23 health-related non-governmental organizations that work together around chronic disease prevention and healthy living in a very comprehensive manner. And since we came together in about 2003, we've been working very actively in supporting advocacy efforts and proposals that affect chronic disease prevention in Ontario. And we act as a networking platform and an advisory table for discussions around these issues across the province, and we provide input on a variety of documents and positions. We've got a very ambitious work plan for ourselves for 2012-13, and just wanted to give you a sense of some of the areas in which we're working. We're looking to increase the degree of influence that OCDPA has amongst our provincial stakeholders. We also are working to increase the sense of engagement and ownership amongst and benefit to our various OCDPA members. And we're looking to identify new opportunities for collaborative action between the members. And finally, we want to continue to advocate and influence the percentage of funding and resources for chronic disease prevention in Ontario. And we've had a number of successes over the past 10 years that have really kind of fueled our desire to continue to champion a comprehensive chronic disease prevention system in Ontario. And we've got several new initiatives this year, one of which is this series of discussion panels that you're participating in today. And the other one is we've kind of relaunched our newsletter called Dialogue. So hopefully most of you either have seen our first edition or will be receiving our second edition, which will be coming out shortly. So as I said, we're constantly seeking new ways that we can promote chronic disease prevention, collaborate and support promising practices, and assist in developing tools and policies so we can really work collaboratively to improve the health of Ontario. Before we get started, I just want to pause for a minute because there are a number of ways in which people are participating. I mentioned we've got close to 200. Obviously, there are not 200 in this room, but we've got about 150 virtual participants today. So we've got a few in-house, which is great. Actually, we've got a full house here at CAMH. And then we also have people who are participating through live streaming, which allows participants both to view and listen in real time via the computer. And just as a reminder for those of you who are accessing us through live stream, that it does require a Flash player and a Facebook account to log in, and that there is a Twitter account which we've got our a hashtag up there, and there's also, I believe, a chat feature. So if you are having some technical difficulties or you've got some questions, please feel free to send them our way via those mechanisms. And if at any point in time, because technology is wonderful, but it's not perfect, so if at any point in time you've got problems when you're live streaming and it stalls, please connect with Adobe Connect, which we've got the URL on the screen as well. So we welcome comments, questions via Twitter. So we've got our hashtag, and so feel free to tweet throughout the event and to, as I said, forward any questions and comments that you may have. We also have a number of people who are participating through a webinar platform through Adobe Connect, and there is also a chat feature for those of you who are joining us that way. So again, if you've got some technical difficulties or you have some comments and questions, please feel free to engage with us that way. And then, of course, we've got the teleconference line. Those of you who are participating via webinar need the teleconference line to both hear and see the slides as they go by. And I do just want to preface the rest of our session by saying we're excited to be able to use technology in this way. We're excited that we've got so many participants, but really this is still fairly new for us, so please bear with us if you know, there are a few glitches throughout the morning. We'll try and take care of them as quickly as we can. So I want to introduce provide a bit more of a context for our session this morning. We had our initial event last month in October, and it was looking at mental health and chronic disease prevention. Where is mental health and chronic disease prevention? And it was very well received, and we're trying to build on the enthusiasm and the energy that was surfaced at that event and continuing on with our series of 5 different discussion forums. We're looking at 5 areas in which OCDPA has developed some key messages, some evidence-informed messages. So those include mental health, high-risk alcohol consumption, that's what we're focused on today. And then we also have sessions coming up on comprehensive tobacco control programs, healthy eating, active living, and physical activity. And each of these panel discussions aims to initiate and generate discussion around 3 key questions that I'm going to share with you in just a moment. We want the focus to explore what action is currently underway, and also then to start thinking about what still needs to happen in order for us to really adequately and effectively address some of these chronic disease risk factors. And each of these discussion sessions, these forums, are going to generate some information which will be very helpful. And then what our plan is to pull it all together into a summative event called Preventing Chronic Disease in Ontario, What Will It Take? And that event in the spring of 2013 will pull together all of the information and really lay a great foundation for some work that we need to be doing here in Ontario. So just again, as a way of background to the work that OCDPA has done over the years, we've got a couple of documents that I really encourage those of you who have not yet seen these to go and take a look at. We have created a document called Thinking Like a System, and it really is recognizing that we've got a number of valuable and important population health assets in Ontario, and that we need coordination and integration to really optimize what we have in place. So that document has a proposed plan and a model for a province-wide system that really enables coordination, planning, and delivery, and continuous improvement of a health promotion and chronic disease prevention system that really focuses on population health. And then we also have a series of evidence-informed messages. I made reference to those earlier. So we do have one on alcohol, high-risk alcohol consumption. And these key message documents, each one takes a look at the risk factors, looks at some of the evidence, the health-related consequences, the costs, and some rationale for action and what that action might look like. So again, some fundamental information in each of those documents. And then lastly, we also pulled together a bit of a toolkit that's looking at influencing healthy public policies. So it really is designed for anyone who wants to work in those areas and encourage change at a local level. And that document looks at a step-by-step outline of the policy development process, has some practical tip sheets, and policy ideas that you could take and run within your local communities. So I do encourage you to go online. They're all available on our website. So today we've got a couple of objectives. We want to really look at increasing our understanding about evidence on alcohol as a risk factor and highlight some effective strategies and initiatives. And then we also want to identify opportunities to take some collaborative action in Ontario. There's lots of work that's underway that's making a difference, but there's lots more that we could be doing, particularly together, to really push that envelope. And so that's what we want to focus on today. So in terms of our agenda, we have a wonderful group of panelists who are going to take a few minutes and present some current evidence and some initiatives at various levels. And then we're going to pause for a Q&A. So give all of our participants, whether they're participating virtually or in the room, an opportunity to ask some questions. And then we're going to move to what I hope will be a fairly engaging conversation and dialogue around moving forward. What is it that we need provincially, locally, to make a difference in Ontario? And that's how we're going to wrap up. And as I said, we will be giving an opportunity for all of our participants, whether it's through live stream or through Adobe Connect, and here in the room, to be as engaged as possible in each of those conversations. So our 3 key questions, I want to just put them up now because I would really encourage everyone to mull these over as our panelists are presenting. These are the questions we want to come back to at the end of our panel and have a conversation around. So we want to look at what are the main action steps that are needed within the next couple of years for government, for us as the Ontario Chronic Disease Prevention Alliance, for researchers, and for individual organizations. So what are some main things that we need to be thinking about doing? What are some concrete action steps that we could be moving forward on? And then also we do need to think about those challenges. What are the challenges or barriers that might impede action in those areas? And then what can we do to minimize them and to overcome those? So I really do encourage you to think about those questions as we go through our panel presentations, and then we'll, as I said, have what I will hope will be a stimulating conversation, and that information will be then fed back into a report and will help form a foundation for our summative event in the late spring. So I'd like to take a minute now and just introduce our panelists, and then I will turn over the podium to them. We've had a slight change in order. Oh, actually, this does reflect the new order. My sheets reflect the old order. That's okay. So we are going to spend some time. Each presenter is going to take a look at, as I said, providing some evidence, talking about some of the work that they're doing, and then we were going to be moving into a Q&A. So I would like just to take a minute to introduce those to you, and then they'll just come up in their order. So our first speaker is Norm Giesbrecht, and Norm is a senior scientist here at the Center for Addiction and Mental Health, and he has a range of research interests which include the impact of alcohol policies on drinking-related harm, drinking patterns, trauma, and chronic disease, and a range of community-based prevention strategies and harm to others. So certainly comes with a great deal of expertise to bring to the discussion this morning. And Norm is going to talk a little bit about some of the evidence around alcohol policies and their contribution to a comprehensive approach. He's going to draw on some research and some initiatives internationally, nationally, and provincially that will feed into that conversation. And then Heather Manson is our Chief Health Promotion, Chronic Disease and Injury Prevention at the Public Health Ontario, and she really guides the technical and scientific advice in the core areas around chronic disease prevention, injury prevention, and health promotion at Public Health Ontario, particularly as they are relevant to the Ontario Public Health Standards. And Heather is going to share with us the rationale and the background for 4 key specific recommendations that were put forth in a recent document the Public Health Ontario and the Cancer Care Ontario released last year. And those are recommendations around issues related to alcohol, particularly high-risk alcohol consumptions and their relation to chronic disease prevention. And she's also going to talk a little bit about some of the challenges to implementing those recommendations. And then Dr. McKeown is the Chief Medical Officer of Health here in the City of Toronto. And he's been an outspoken advocate for healthy public policy and action to reduce health inequities. And he's been the Chief Medical Officer of Health for the last 8 years at Toronto, and certainly been involved in public health for a number of years. So again, comes well recognized, lots of credibility to bring to this discussion. And he's going to look at some of the alcohol-related program, policy, and advocacy action that can be taken at a local level, talk about some of the successes that Toronto Public Health has had, and again, some of the challenges in advancing healthy public policy at that local level. So without further ado, I'm going to turn it over to Norm, our first speaker. And so again, hold your comments and questions because we will have an opportunity at the end following our three speakers for them to become available to answer your questions.
Thank you very much. I'm very pleased to present to you this morning. This quote is from the World Health Organization, and it indicates the level of damage from alcohol worldwide. And you can see that it has also a very big impact on young people between the ages of 50 to 29 years. So overall, 2.5 million worldwide died from alcohol-related causes in 2004. This slide summarizes the impact of alcohol from in high-income economies such as Canada. So you can see that it is second to tobacco. Worldwide it's third, and in here it's second in high-income economies. And then the reference in the back is useful because if people want to check it out, they can go to that document, the documents online, and they can look at it. And you can see that it's a very important issue and often underestimated. And by the way, these estimates take into account the health benefits from alcohol. So they have been, they're the net damage. So the health benefits have been subtracted, if you will, from these estimates of alcohol-related damage. Now, alcohol-related harm in Canada has a wide range. And I'm just going to highlight a few things. You can see the trauma, violence, and social disruptions. There's also harm to others, not only the heavy drinkers impacted, but also innocent children. Other innocent victims are impacted from alcohol through family violence, through drunk driving, through workplace incidents, and so on and so forth. And it interacts with other risk factors to increase health risks. And there are many public myths about the health benefits and harm and costs. It's often assumed, for example, that if some alcohol is good, more is better, and even more is excellent. And so I think there's lots of misconceptions about the benefits of alcohol. There are some public health benefits, but they're often exaggerated. Now, here you can see the. Am I going too quickly, or is it fine? Good speed. Okay. Here you can see the trends in alcohol sales. Since about '96, there's been an increase in alcohol sales, and I should emphasize that the level of sales in a population are a very good general indicator of the level of damage. So if you have populations that sell more alcohol, they tend to also have higher rates of damage. Not only just drinking and driving or liver cirrhosis, but a wide range of chronic problems and social problems and other types of various types of trauma. You can see here 13% of Canadians exceeded the lowest drinking guidelines in the past week in 2009, and 31% of men and 21% of drinkers age 15 and older reported heavy episodic drinking at least monthly. And that refers to 5 drinks or more per occasion. So among drinkers, actually a fairly substantial percentage drink in a risky manner fairly regularly when this survey was done a couple of years ago. And this increase in heavy episodic is increased among women overall, which I think is quite a shift from some decades ago. I think some decades ago you would find that there was a big gap between heavy drinking among men and women, but now I think this gap is closing. That there's quite heavy rates of heavy drinking among women as there is among men. Here you can see the trend data for alcohol sales for the 10 provinces of Canada. We did not include the territories in this, and you can see that there was, as I indicated, there was a drop for a few years. Then it has been increasing since about 1996, and the same time period, if you will, but grouped here by the provinces from Quebec onward, and you can see roughly the same pattern increase since 1996. This is alcohol sales per adult and older, and that's a conventional way of calculating consumption. By age 15, about 50 or 60% of the population has had a drink, and this is in pure alcohol, so it includes beer, wine, and spirits combined. Here the same patterns, or the same time frame again, and for the provinces from Ontario westward, and you can see that there's some variation of provinces. The pattern is very similar, and some provinces, BC and Alberta, have substantially higher rates than some other provinces. Now this is a slide, interesting slide that was provided by me, Denise DePape and Tim Stockwell, and what it shows is that, this is in BC, it shows that in a few years it is estimated that the alcohol attributable hospitalization will be equal to that from tobacco. And that is, I think, due to two factors. That in British Columbia there's been a very dramatic increase in access to alcohol with partial privatization. That's one of the factors. And I think there's been very substantial tobacco control efforts in British Columbia. So you have these two things happening, and so I think that there's cause for concern with regard to the evidence shown in this particular slide. Oops. Now, so there's some number of challenges that need to be addressed, and I've listed 7 here. The misperception is that if you have a good alcohol control policy, you're prohibiting alcohol. Well, none of the recommendations that I'm going to list in a few minutes prohibit alcohol. Not a single one of them. None of them are prohibitionist. They're saying you need to have better controls, but public health-oriented approaches. I think there was a survey done a few years ago by Cancer Care Ontario, and a very small percentage of the population were aware that alcohol was carcinogenic. It's really the awareness of alcohol and its relation to chronic disease is really relatively small in the general population. There's a lot of opposition to effective policies, and such as control on the number of outlets per capita. This is a very unpopular notion and is really not supported. Whereas there's often resources to initiatives that are really not very effective. We do not have full cost accounting on alcohol, and it's related to this second last bullet. The media is typically blind to precautionary issues. If you can just think of all the times you heard about discussions in the media about privatization of alcohol outlets, almost all of the stories are about, well, what inconvenience, the privatization is necessary to solve inconvenience. There is hardly any reference, if at all, to the public health consequences of privatizing alcohol outlets. So it's a very sort of biased view, and there's not a full cost accounting of the damage from alcohol that might arise or likely to arise from privatization. So there's contrasting trends. On one hand, you have increasing access to alcohol, as indicated here, and density of outlets increasing, especially in British Columbia, for example. There's discount pricing and many loopholes. There's multimedia marketing and social media. And then in contrast to these top two trends, the access and high exposure to advertising, you have international, national, and provincial initiatives. You have the World Health Organization has a global strategy on alcohol. Public Health, Pan American Health Organization has had some statements on alcohol issues. There's a national alcohol strategy from 2007. There's the CCO Public Health Ontario document you'll hear about, and the CPHA's position paper on alcohol. So you have, on the one hand, a lot of effort to increase drinking, to make alcohol more accessible, to make it cheaper, and so on and so forth. On the other hand, you have the public health community trying to provide a more precautionary approach to the use of alcohol. So some of you may know about this book It was published in 2010 by Oxford University Press, and it was supported by the Pan-American Health Organization. And as you can see, there were several people from Canada as part of the list of authors that came from different countries around the world. What we did is we assessed literature on these topics, and there were 43 different interventions that we looked at. So these are all under these different tactics. Various pricing interventions, some on physical availability, some on the drinking context, like where alcohol is sold and served, education, persuasion, regulating the alcohol promotion, drinking and driving countermeasures, and so on. And we assessed all of them on several criteria. One criteria was, what is the evidence of impact? What is the scope of the impact? And how widely was the research? Was the research all done in one country, or was it done in different cultures and settings? And the evidence of impact, again, was assessed on 3 criteria. Did it change drinking behavior? Did it reduce drinking behavior? Did it reduce high-risk consumption? And or did it reduce problems from alcohol? So it had to meet one of those 3 criteria to be considered to be effective. And after looking at 43, we came up with this list of best practices, and you can see that a number of them are on the drinking and driving arena. And you may ask, well, why is that? Why is it so skewed to drinking and driving? And I think the answer, to me at least, is quite obvious. Because over the last 50 years, governments and non-government organizations have spent millions of dollars to try to combat drinking and driving. And by doing that, they've been evaluating their initiatives, and by evaluating, they've come up with good policies. And so you can see the random breath testing, lowering of BAC limits, administrative license suspension, graduated licensing for novice drivers. These made this list. Not because we were loading the dice in any way to drinking and driving, it's because there just has been so much effort to try to control drinking and driving, and we are doing so much effort and evaluating the effort to come up with good strategies. And you can see a number of these are also relevant to alcohol and chronic disease. The government of monopolies, restricting hours and days of sale, alcohol taxes, lower alcohol strengths, brief intervention, and treatment and detox. So all of these have an impact on potentially reducing alcohol-related chronic disease. So in the last part of my presentation, I'm just going to focus in on this report, and I'll give you the web link in a few minutes. How am I doing on time, Barb? Okay, good. So this was commissioned by the Canadian Public Health Association. It's called a position paper on alcohol. And to be a little bit modest about it, I think Canada is the only country where a national public health agency, public health organization has put a position paper on alcohol. There's one. The American Public Health Association does not have one. I don't know if the British one or the Australian or the other countries have position papers on alcohol. So this was commissioned by CPHA and was finalized, as you can see, about a year ago. These are the members of the working group that developed the paper, and what we did is we developed a draft amongst ourselves back and forth many times. Then we sent it out to about 10 or 15, maybe 15 different people to review, give comments. Then we had a session in June of 2011 at the CPHA meeting, where we had presented it, and we had lots of feedback and comments and criticisms, revised it some more, and then we sent it to the CPHA leadership, to their policy committee, and they eventually approved it. So I think you can say it was peer-reviewed. So we had, I'll skip right to the chase here. Basically, we had 2 types of recommendations. We had population-level recommendations, and we had focused interventions. And we all feel, or we all maintain, that both are essential for a comprehensive approach, but the population, both are important for a comprehensive approach, but the population ones are essential. If you have only focused interventions and no population-based interventions, it'll be very, very, very difficult, if not impossible, to have an impact on alcohol-related chronic disease and other alcohol problems. So I'm just going to quickly run through the recommendations on into these four categories. Alcohol pricing policies, and this is very timely. I think there was a news a day or two ago that the UK has just raised their minimum price with regard to alcohol. So you can see adjusting the federal tax based on alcohol strength, so that the stronger alcohols would be taxed higher. To strengthen the minimum reference price to alcohol, ensure that U-brew outlets are consistent with minimum pricing, and implement a provincial surtax on alcohol beverages disproportionately consumed by youth. So there's lots of concern about drinks that are consumed by youth, such as drinks that are combined with caffeine, for example. So there's a number of recommendations here on the pricing policies. We also had some recommendations on physical and legal availability, to have a moratorium on retail outlets or increase the hours until a review is completed, to not permit sales in corner stores or do not expand the private network if currently permitted. This is also very timely. There are now initiatives, I think, to dramatically increase the number of private wine stores in Ontario, and I think this is a very timely recommendation. To maintain the legal age of 19 and consider increasing to age where it is 18, and to ensure compliance with legal age with a valid ID. Curtailing alcohol marketing, restricting advertising, and incrementally with the aim to have a system similar to tobacco control. Regulating all forms of marketing, including internet, social media, and product placement. Explore legal options for provincial territory restrictions on advertising, promotion, and sponsorship. Currently, there's federal regulation, but it's actually managed at arm's length from the federal government. The federal government used to manage, CRTC used to manage it directly, but now it's managed at arm's length. And so we felt it was necessary to have some further restrictions with regard to advertising. Regulating and monitoring alcohol control systems. Canada is unique in that it is one of the very few countries that has liquor boards. The U.S. has about a third of the states have liquor boards in the U.S., and nine of the 10 provinces have retail alcohol liquor boards in Canada. Some Nordic countries do, but most countries do not have liquor boards. And I think it's very important that the public health community support the liquor boards, and particularly support the public health and safety reduction, harm reduction, and safety and promotion aspects of their mandate. And so this was part of the thinking behind these particular recommendations. Now, focusing on targeted policies and interventions. And we looked at 4 main topics: countering drinking and driving, changing the drinking context, educating and promoting behavior change, increasing access to screening and brief interventions. So these drinking and driving topics are going to be no surprise to anyone who's aware of the work that Mothers Against Drunk Driving have been doing for years. And I think we borrowed quite heavily from their work. And so you can see we're starting from a long history of controls on drinking and driving. So we're adding some nuances to it, if you will, not starting from scratch. And you can see there's a number of recommendations here with regard to drinking and driving. We also think it's very important to build on the current work that has been done by many organizations with regard to the drinking context. Ontario has a risk-based licensing for a licensed establishment, but not all provinces do, and so this is a national report, so we felt it was important to put that in there. Increase the capacity of authorities to enforce regulations. I think there's quite a bit of variation in terms of the number of inspectors per outlets, for example, or number of inspectors per people of drinking age by province, and I think there's lots of room for improvement there to increase the number of inspectors. To implement evidence-based bar safety and responsible serving training, and a lot of there are server training programs, but in many cases they really have been systematically and thoroughly evaluated in terms of their impact. They may be excellent, but until you evaluate them, you really don't know how excellent they are. Enhance the training of owners and managers and staff as a condition of licensing and license renewal. Again, some provinces do well on this, and some provinces can do better. We also had some recommendations about promoting behavior change, ensure that these strategies are evaluated and only those demonstrate effectiveness be implemented. Funding social marketing campaigns to denormalize the acceptability of harmful alcohol use. Explore adding health warning labels and information on new low-risk drinking guidelines in combination with other marketing and population-based interventions. So we felt that there's room to explore what could be done down the road. And on this last point, I think it's very important that there be really concerted efforts to get the low-risk drinking guidelines into the hands of the people who are drinking at high-risk levels. It's well enough to have the guidelines known by people who drink at low-risk levels. That's wonderful. But I think you need to get it to the population that needs to change their behavior. And I'm not sure how to do that. But that's a real big challenge in that area. And last but not least, to increase access to screening and brief interventions. I think it's very important to have both population-level policies, but also to provide the resources that people who are struggling with alcohol so that they can change their behavior. It's one thing to say, well, you're drinking above the low-risk drinking guidelines. Well, then what are they supposed to do? They need to have professional, evidence-based advice and access to that advice, easy access to that advice, so that they can change their behavior. So we had some recommendations on that point as well. So we had also some cross-cutting activities, surveillance and research, knowledge exchange, and skills building. I won't go into detail there, but what I've given you is a snapshot of the recommendations from that CPHA report that was released about a year ago. And here's how you can access the paper. For those in the room here, you may I can leave it up, or you can ask me later how to get that. But it's very straightforward. Just go to CPHA and put on alcohol position paper, and I'm sure it'll pop up there. And I'd also like to acknowledge Ashley Wetlaufer, Denise DePapp, and Tim Stockwell for helping provide some slides, and also members of the working group on CPHA's position paper on alcohol. And here's how you can reach me if you wish, and thank you so much for your attention.
Thank you so much, Norm, and we're going to turn the podium over to Heather now.
Great. Okay, thank you very much. So I'm Heather Madsen. I'm the Chief of Health Promotion, Chronic Disease and Injury Prevention at Public Health Ontario. And I'm going to be speaking really from a provincial level, building on Norm's presentation and many of the recommendations you're going to see echoed in my presentation at the provincial level. I'm also going to be building on a report that we released with Cancer Care Ontario last year in March. This was a partnership project. The report is called Taking Action to Prevent Chronic Disease, Recommendations for a Healthier Ontario. I'll tell you a little bit about the report, but it really shapes what I'm going to be discussing today. So I'm just going to echo many of the comments you already have heard, but consider it as being just reinforcement. So what do we know about alcohol consumption? Norm has already mentioned that alcohol is carcinogenic to humans, cancer of the oropharynx, larynx, esophagus, colon and rectum, liver, and female breast. And there is no lower level. There's just a line that goes up like that. In contrast, people do tend to know about that protective effect for cardiovascular disease and all-cause mortality, that J-shaped curve, but there is no acceptable lower level in terms of the carcinogenic effect of alcohol. Norm mentioned that that's not widely known, and I think it is something that we could all draw greater attention to. As well, there is a relationship between alcohol consumption and heavy alcohol consumption and type 2 diabetes and cardiovascular disease. And again, we tend to hear about the cardioprotective effects of alcohol and tend to hear less about the relationship with atrial fibrillation, congestive cardiomyopathy, hemorrhagic stroke, and even type 2 diabetes. As well, Norm mentioned that we were focused here in our report on chronic disease, but Norm mentioned about family violence, injuries, trauma, and social disruption. So there's a whole host of other health consequences and social consequences of alcohol consumption. In terms of the alcohol use patterns in Ontario, I'm going to be showing you some up-to-date slides about this, but basically about 22% of adults exceed the low-risk drinking guidelines. I'll show you the slides. I'll move into that. And Norm also talked about that there is a misconception that the financial benefits of alcohol exceed the costs, and in fact, in Ontario, estimated Canadian data 2011, 1.7 billion in direct care costs and 3.6 billion in indirect costs in Ontario. So these are some slides that were put together for me by Jeremy Herring in Public Health Ontario. Jeremy is an epidemiologist. And this looks at the proportion of the population exceeding the low-risk drinking guidelines, age 19 plus, both sexes combined, in Canada and by province. And it's a weighted percent over here. Now, this data was generated by using CCHS data, and it's the recent the National Low-Risk Alcohol Drinking Guidelines. So just to show you where things are at, sorry about that. Ontario is the second lowest. We're actually below the Canadian average, and you can see the territories are over at the right hand exceeding. And you mentioned the higher consumption in Alberta and BC. And Alberta is over there above the Canadian average as well. The numbers, because this is a weighted percent and it's the new low-risk drinking guidelines, and it is only really looking at two of the guidelines, which is daily consumption, number of drinks per day and in a week, and not binge drinking. The numbers are different than the percentages that you saw in Norm's presentation. So I think what I'd like you to focus on is the relative amounts here. And this slide really looks at the proportion of the population by age group that are exceeding the low-risk alcohol drinking guidelines in 2009-2010, and you can see that young adults have the highest proportion exceeding the drinking guidelines, and as people get older, that goes down. This is just showing that data in a different way. It's just a little bit more continuous across age groups with confidence intervals, and it's just interesting to see how high that is in the lower age groups and how that comes down as people get older in the older age groups. This is an interesting slide in that it is looking at the proportion of the Ontario population, again a weighted percent, exceeding the low-risk alcohol drinking guidelines by income quintile. Now, the way that this was calculated, people who abstain are considered as being in compliance with the guidelines, the way that we use the CCHS data to calculate this. So given that there are other factors correlated with low income, perhaps ethnicity, for example, or that may also have a relationship with abstention, that may be one of the reasons why we're seeing this pattern. There may be other reasons as well, and certainly I'm interested in hearing from Norm about what he thinks are some of the underlying factors that help us to understand why we see this gradient by income. We can come back to that perhaps, Norm. This information comes from a report that we put together with ISIS and released in October. Report is called Opening Eyes, Opening Minds, the Burden of Mental Illness and Addiction in Ontario. And this looks at burden. You can look at burden in different ways. So you can look at prevalence of the condition, you can look at health outcomes, you can look at costs, healthcare utilization. In this case, we used a measure called Health Adjusted Life Years, and this is a composite measure which takes into account years of life lost due to dying early, YLL, plus years lived at reduced and less than full function. So for example, if someone had cirrhosis of the liver, or if they had been in an alcohol-related motor vehicle accident and had a disability related to that. So that's the composite measure. Now, this is similar to the disability-adjusted life years, a little bit different calculation from the WHO Burden of Disease report that Norman referenced. And in our calculations for all, you can see the burden of all mental illnesses and addiction combined as being so extremely high, and certainly exceeding that of all cancers in Ontario and all infectious diseases. And you can see that in our data, alcohol was ranked third. Now, this may be because we actually were not able to capture the full burden of alcohol in Ontario. The data, for example, excludes when alcohol was not listed as the underlying cause of death. So this is an underestimate of the burden of alcohol, but you can see that it's very high. And this is just looking at how that burden distributes itself by age group across the population. And of course, it's higher in men than in women. So this is a little bit about our report and the guideline, the recommendations that we developed. The report was a collaboration between ourselves and Cancer Care Ontario. Because we were looking at how can the province take action to reduce chronic diseases and the related morbidity and mortality, we looked at the 4 main risk factors of chronic disease: alcohol, tobacco, unhealthy eating, and physical inactivity. I'm going to talk about the recommendations that were developed for alcohol. And focusing on these risk factors aligned with the UN Summit on the Prevention and Control of Non-Communicable Diseases, which occurred in September 2011. We also considered key system enablers and the impact on health equity, and the report was released in March. It's on our website. So we had a working group for each of the risk factors. Norm was involved, and many of his colleagues who were involved in the CPHA position paper were also involved in that expert working group. The recommendations needed to be within the government's scope of control to directly implement, supported by the strength of evidence, and reflecting the level of development of the risk factor domain. And we limited this to 4 recommendations per risk factor. So the alcohol recommendations, and I guess one of the things I'd like to say is you'll see the strong alignment with Babur et al. 2010 and also with the CPHA position paper recommendations and the particular areas of focus. But also this does reflect where things are at in Ontario. So Ontario has a number of the elements which would be included or are recommended in Babur et al. 2010 in the CPHA position paper. So some of the language that we've used is maintain and reinforce those. Don't let any further slippage occur with respect to what we've already got. And then strengthen. So language around maintain and reinforce and strengthen. So I guess the question is, how do we maintain and reinforce, and how do we strengthen? So here are the recommendations. The first is to maintain and reinforce socially responsible pricing. Babur et al. In the CPHA position paper mentioned pricing and taxation as a key intervention area. In Ontario, this can be done by establishing a minimum pricing per standard drink across all beverages indexed to inflation, maintaining average price at or above the consumer price index. And from my conversations with Patrick Ford, Patrick, you might want to just indicate yourself from, and Patrick from the LCBO advises me that in fact we are indexed to the CPI, and we do have a minimum price. It's across standard drinks. Have I got that quite right? Sorry? Across all products. So maintaining the prices, maintaining it at or above the index to the consumer price index, and then adopting disincentive pricing policies for higher alcohol content beverages. And Patrick has also gave me an interesting anecdote a couple of months ago where there was a high alcohol content beer product that was being sold. And this was particularly attractive to young drinkers. And the price was put up, the consumption came down. So this actually works. Pricing is an effective disincentive strategy. And similarly, Ontario, when there was caffeinated beverages and caffeinated alcohol beverages, Ontario established maximum caffeine contents, which resulted in product reformulation. I'm using these examples to show that, in fact, pricing works. It does reduce consumption when the price goes up. And, in fact, establishing standards will result in reformulation. And there is evidence that disincentive pricing is associated with lower alcohol consumption and reduces alcohol-related harms. And to be effective, it should be indexed to inflation. Our next set of recommendations, again aligned with Babur et al. And with the CPHA position paper, are around ensuring effective controls and availability. And there has been a gradual loosening over time in Ontario of those controls. So I think what I've heard is that there was the last call has gone from 1 to 2 a.m., as I understand in Ontario. In addition, alcohol is made available on festivals. I think that will happen in May of 2010, 2011. As well, there has been a gradual slippage over time, is really what I'm saying. And so what we're recommending is that ensure that there is no additional slippage, no increase in hours of sale, and no increase in the overall population density of on or off-premise outlets per capita. and not undertaking further privatization of off-premise alcohol sales. So you'll recall the recommendation in Babur et al. Around government monopolies. So Ontario has the LCBO, and we've seen the experience in BC where partial privatization has resulted in increased sales, and I think that's of wine products. Now, so the rationale is easy access to alcohol. It does relate to increase in consumption and high-risk drinking and alcohol-related problems. And there is strong evidence to maintain a government monopoly on off-premise alcohol retail sales. Now, in terms of this next recommendation, it's targeted controls on alcohol marketing and promotion. And our group of scientists involved with the report felt that this was an area that needed to be explored because of the risk of lifestyle promotion which targets particularly youth or at-risk drinkers, and marketing efforts that encourage high-risk drinking. I'm going to just show you one quick graphic. This picture was taken by a colleague and emailed to me about a month ago. It's from the LCBO in the Cloverdale Mall in Etobicoke, and this is a marketing associated with a particular product. The tagline, of course, is Whiskey Rocks, and it looks like it's a young person who's playing a guitar and looks kind of having fun. This is actually outside the LCBO in the mall. This is a life-size ad, and there were 3 of these in a row. So, and I'm sure you've seen some of the alcohol ads on television. Similarly, young people, they're having a good time. You don't necessarily see them drinking explicitly, but they're clearly young, healthy, having a great time, and so there's a certain lifestyle promotion effect going on here. I also wanted to reference, I thought it was fascinating, the series that were done by Ann Dowsett Johnson in the Star last year, and one of the about women in alcohol. And you'll recall there was a particular product, I was mentioning this in Toronto last week, called Mummy Juice. And I'd like people to go online and Google Mummy Juice. It's absolutely fascinating. Last time I Googled it, there's a bar running down the side of the website that talks about all of the reasons why moms, the daily stresses, changing diapers, driving kids to school, soccer games, music lessons, fevers, doctor, dentist. The idea is time out, you need a break, Mummy Juice is your answer. So, this is really where I'm going around lifestyle promotion. What message is that? Interesting story about how this particular producer developed that name. One of her kids was pointing at her glass of wine and said, "That's Mummy's juice." And that's where she got the name for her product. So the next recommendation again was referenced by Norm, and that's around increasing access to brief counseling interventions. And there is strong evidence that significant reductions in alcohol consumption and alcohol-related problems can follow brief intervention counseling. So potential barriers to implementation, and these are potential because we have some elements in place in Ontario. Let's make sure that we reinforce and maintain those and strengthen where we need to strengthen. So potential barriers to implementation, we've already heard some of these from Norm. Alcohol is consumed more than any other harmful substance, but actually action to control it may be seen as unpopular in the public. We have to bear that in mind. Norm mentioned the narrow medium public perspective on alcohol-related harms compared to potential benefits. We have an infrastructure in place, but we don't have a strategy around it. Misconceptions, Norm mentioned this, of the importance or financial contribution of the alcohol industry. Different economic and political priorities among sectors and government departments, and then the challenge of engaging all relevant sectors to create healthy public policies. I've chatted just very briefly about the marketing, promotion, and advertising initiatives, and I've also mentioned the gradual erosion over time of control on alcohol sales. So to address the risk factors for chronic disease, we do need concerted action at all levels and across all sectors. There's a challenge of engaging all relevant sectors. Just if I could go on. There's strong evidence to support action on pricing policy, etc., that Norm has already mentioned, that I'm echoing again. And public health should focus on changing the public's perception of alcohol. And particularly, I think there's really an opportunity to talk about that no lower, acceptable lower level with cancer. as being one opportunity, and also to talk about some of the other issues around women and drinking, around drinking on campuses, the sorts of behaviors that we're starting to see emerge, the closing of the gap between women and men. So I think there's a number of new kind of issues that are emerging, and I think there is an opportunity to draw attention to those issues and to change the public's perception of alcohol, and to work with government to maintain and improve the current alcohol controls. So this is the end of the presentation. I just wanted to let you know that you can Google our website and find the report, Taking Action, the main report, plus we have quite a detailed technical appendix that goes with that. And I wanted to thank a couple of my colleagues, first of all Norm, who really contributed to this effort, as well Brian Hindman, who was the author for this particular section of the report, Ben Rempel, who's with our Alcohol Policy Network with Public Health Ontario, Pat Haw and Jeremy Herringhead, who helped to put together this slide deck. So thank you very much. Shall I pass it over to David?
Well, thanks both to Heather and Norm for setting the context in terms of what's happening across the country and in Ontario, outlining some evidence and some areas in which we need to be contemplating and looking to do some further work. So it's a great segue now to have David come up and talk about what is happening and what potentially could be happening at that local municipal level. So thank you, David.
Thank you very much, Barbara. So you can see there's kind of a geographic progression in the panel today, from national, international, to provincial, to a local perspective. I'm going to try and bring you a bit of that local perspective from the point of view of one large urban area and its public health agency, the Toronto Public Health. Here's what I'm going to be talking about: a brief overview of Toronto Public Health and the City of Toronto, some of its characteristics which are pertinent to what we're discussing today. I'm going to highlight some of the key program, policy, and advocacy initiatives that we've been working on in the city. I'm going to reflect a little bit on some of the successes and challenges and opportunities in this area for local work. The City of Toronto, as everyone knows, the largest city in Canada. We have more than 2.5 million people. Very diverse population. I think that's important for the topic at hand. It has a bearing on patterns of alcohol consumption in the city, and has a bearing on how we approach that, both in our policy and advocacy work as well as in direct service. The City of Toronto has about half the population, what Statistics Canada calls visible minority, which we tend to call racialized communities. About half the population was born outside Canada, and that means that our patterns of alcohol consumption are somewhat different than the rest of Ontario. Generally, our patterns are lower in terms of overall average consumption, because there are a number of communities, significant communities within the city, in which alcohol consumption is not normalized in the way it is in conventional mainstream North American society. So about 75%, about 3/4 of the population, use alcohol, and only about 13% use it at a level which we considered hazardous or harmful. We still have significant problems. Binge drinking in youth is up around 16%, so there are very significant levels of alcohol consumption of concern, but on average they're somewhat lower than the rest of the province. Now, Toronto Public Health is the local health department serving the City of Toronto. We have a mission which is to reduce health inequalities and improve the health of the entire population, and under the provincial public health standards, we have responsibility for delivering a very wide range of direct services, as well as acting as advocates for public policy. And these are the two components which are laid out in the CPHA position statement with respect to alcohol, and we do pursue both in all of our program areas. On the direct service side, there are a number of initiatives that we offer to the population of Toronto under the substance misuse prevention program area. Those include programs like Youth in Control and Party in the Right Spirit, which are peer-led health promotion programs for high school youth and post-secondary students out in the community that promote safer partying and safer driving. A number of our parenting programs also address alcohol indirectly. We help deliver the Strengthening Families programs with the Center for Addiction and Mental Health and other community partners. It's a resiliency-based prevention program that involves the whole family and is very often targeted to families that have issues with substance misuse. Another parenting program called Kids Have Stress Too is a program for parents of younger children that promote positive mental health and try and lay the foundations in family dynamics for inoculation, if you like, against unhealthy behaviors like alcohol use at levels which are harmful. We also, in a variety of different program areas and a variety of different venues, provide information drawn from the evidence that you've heard presented today for a wide range of audiences, for children, for youth, post-secondary students, parents, teachers, and other service providers. And this information is delivered in a variety of different venues and ways through participation in schools and community events, group presentations, and sometimes broader social marketing campaigns. In our work with workplaces, there's also a component by which we assist workplaces in Toronto to develop policies regarding alcohol use, both in the workplace and for their worker populations and for the organization. So we work that into sort of healthy lifestyles programming for workplaces. Lately, we have been working to promote the relatively recently released and updated low-risk alcohol drinking guidelines. We're in the process of developing a multifaceted campaign. Our initial focus has been on young adults, and we've been testing it out or showcasing it at some recent events here in the City of Toronto at the International Women's Show, and going right into the belly of the beast at the Food and Wine Show. Talking about what the low-risk drinking guidelines say about what you can drink and how much you can drink before you get into that zone of harm. I think that generally speaking, there has been public education around how much you can drink before driving. There's quite a lot that's gone into that. There's not the same level of awareness, I believe, in the population about where the boundary is between alcohol consumption, which will not lead to important chronic disease harm, and that which will. So I think there is work to be done in that area, and I think the low-risk drinking guidelines give us a good basis for that work. Municipal alcohol policy is important at the local level because it sets an example for the community as a whole, and also helps to serve to reduce harm at events in which there is alcohol consumption on municipal property, which covers quite a lot of the activity in most municipalities. So the first municipal alcohol policy that was developed in Toronto following the big municipal amalgamation was in 2001. It promotes health and safety at events on municipal property, so it's not only municipal events, it's anything that's on municipal property. We're currently in the process of reviewing and refreshing the Toronto municipal alcohol policy, and that work is a collaborative piece of work between Toronto Public Health and other parts of the city government, our municipal licensing and standards department, Parks, Forestry and Recreation, and is intended to bring it up to date with respect to not only the low-risk alcohol drinking guidelines, but also changes to the liquor licensing laws in Ontario, and directions within the broad Toronto drug strategy, which I'm going to be speaking about in a moment. So we want to bring that up to date so it is a state-of-the-art document and policy for the City of Toronto. The policy advocacy part of our work has been operationalized through the Medical Officer of Health and the Board of Health, and very often is done in collaboration so that we have a coherent message coming from a variety of different advocates. So we have, over the past decade or so, advocated for strong alcohol control policies based on the evidence that you've heard. We certainly have wanted to maintain alcohol distribution in public hands, and so on several occasions in the past decade when the issue of privatizing the LCBO has come up, we've been among those who have lent our voice to efforts to maintain that public policy control. Certainly we've been advocating around drinking and driving measures, policies such as blood alcohol concentration limits for driving. We've advocated around provincial taxes, restriction of advertising, essentially all of the evidence-based measures that you've heard summarized in the last two presentations have been the subject of local advocacy, as I said, again, often in collaboration with others. We also think it's very important for all of these to be embedded in a comprehensive provincial alcohol strategy, something which is absent in Ontario. Our collaborations have taken several different forms. One important one has been through the Toronto Cancer Prevention Coalition, an organization which was set up by the Board of Health about a decade ago to focus on cancer prevention. Recently, it's played a very important role in alcohol policy dissemination. There's an alcohol working group of the coalition which developed a report called Alcohol, Cancer and Other Health Issues, an Action Plan for Prevention. And Norman Giesbrecht played a very important role as a member of that group and the co-author of that report. It served as an opportunity to emphasize the link between alcohol consumption and cancer, which is something, as we've said in this presentation today, is not as well understood as the link between alcohol consumption and some other health outcomes. We took that report to the Board of Health, which endorsed it and gave it some public profile. In addition to drawing attention to the relationship between alcohol and cancer, it also provided an opportunity to reiterate the evidence-based health policy approaches to alcohol, to reducing alcohol harm, which we've been talking about today. Not the first time that Toronto Public Health has done that, but we did it we're very appreciative of the efforts of the Cancer Prevention Coalition to assist us to bring these issues forward once again. We've also collaborated with a number of the other groups that are listed on this slide in order to try and ensure that we're sharing information, that the advocacy is coherent and clear and brings as many voices to bear as possible on these public issues. The Toronto Drug Strategy I'm just going to speak to briefly today because it's a much larger topic. This is a comprehensive document dealing with both illicit drugs and alcohol, which was approved by Toronto City Council in 2005. It's a classic four-pillar approach, and the development of it was led by Toronto Public Health, and our staff support the implementation of the strategy. Susan Shepherd, who's here today, is the manager of the strategy. We work with a multi-stakeholder group, an implementation group, to bring all of the perspectives, whether it's law enforcement, health, licensing, and others, to bear on a variety of different issues. In the area of alcohol, the drug strategy has served as yet another focus for advocacy, for strong public policy around alcohol. Just one initiative that give you a sense of the kind of work that's being done is the Toronto Safer Nightlife Committee. It's a partnership of Toronto Public Health, other parts of the city government, the Alcohol and Gaming Commission of Ontario, Centers for Addiction and Mental Health, local business improvement area associations and bar owners, and it's looking at how do you allow entertainment facilities in the City of Toronto to operate with minimum harm from the point of view of alcohol consumption. So they've done things like organize workshops for licensed establishments in Toronto to talk about alcohol liability issues, which gets the attention of operators, to talk about policy development for those facilities, and the associated health issues which are part of that scene, including things like pre-drinking and binge drinking. The group has also served to promote the Centre for Addiction and Mental Health's Safer Bars program, which is aimed at preventing violence and other harms in and around licensed establishments. And here's an area where I think you can tap into a level of community support, because local communities are very concerned about what happens in their neighborhoods. They're concerned about the impact of over-drinking on the neighborhood, people spilling out of licensed establishments, causing difficulties on the street. It's one of the areas where you can garner a little community support for alcohol control. I hesitated a little bit to put the title Successes on this slide because I think there's still many, many things that we need to do. I do think, however, that we've had some success in building those intersectoral collaborations, and those, I think, provide a very strong foundation for advocacy for effective policy. We do need to continue to expand what we do in the direct service side to make sure that our prevention programming is based on the best available evidence and is reaching the parts of the population where it can do the most good. And I think that the sort of collective, coherent policy advocacy from many voices has produced some results. We have been successful so far in resisting the pressure to privatize alcohol sales and distribution in Ontario, and we've seen some policy changes which have served to strengthen existing regulatory legislation. So we're a little forward on some areas. Challenges are that we've fallen back in others, and you've heard Heather talking a little bit about some of the changes that have happened around alcohol regulation, particularly for consumption in public. There is a real challenge. I don't think that the level of public support and public understanding of the challenges of the health harms of alcohol is as high as it is for many other issues, if you compare it to tobacco, for example. There still is wide normalization of alcohol use in society, and the public doesn't, I think, really understand the link between availability, overall consumption, and harm. It's not really an intuitive thing. If you think of, people think of themselves as making choices about their behavior and not being influenced by availability. We ran into a very similar dynamic recently with the discussion that's been happening in the City of Toronto around building a casino. Very similar evidence in terms of increased availability leads to increased harm. It's not something which I think is readily understood. And those of us who are arguing for reduced availability on the basis of the evidence, which I think is very clear, risk being seen as cheerless killjoys for not wanting to have everybody have as much choice as possible. We're also hampered, I think, by a lack of senior government leadership, both provincially and federally. We've already talked about the lack of a coherent provincial strategy. The federal government's national anti-drug strategy doesn't include alcohol. It's a real missed opportunity. So we're not seeing the kind of higher level leadership that we might hope to see from our senior levels of government. And as I said, there is a general lack of support for regulatory measures. It's important, I think, going forward to continue to try and maintain the controls on alcohol that we have, despite a changing political environment. Whatever political party is in office, whatever the current political thinking is, this should remain a key priority for anyone who's concerned about the harm caused by alcohol. We need to continue, from a health sector point of view, one of the big roles that we can play is to continue to emphasize and educate the public about the link between alcohol and chronic disease outcomes. That's a key role, I think, for public health. And lastly, I think we need to continue to be concerned about patterns of drinking among youth. The patterns, like so many other things in life, patterns established in youth can set the tone for patterns later in life, and binge drinking and pre-drinking are significant concerns. I would suggest it is important for us to continue to work on coalition building and keeping that advocacy coherent across sectors, continuing to build on what we have been talking about in terms of the health impacts and costs of alcohol use, and take advantage of some of the leadership which is happening internationally through, for example, the WHO Global Alcohol Strategy, and some of the work that's been is happening nationally, not from the federal government, such as the development of the National Alcohol Strategy that the Canadian Centre for Substance Abuse has been working on. So there are some places that we can hook our efforts onto to try and achieve that degree of coherence in advocacy. And that's the end of my remarks today.
Well, I just want to take a minute and thank our three panelists. The synergy and the flow between the three was quite remarkable, and so thank you so much for building, I think, such a powerful message, and certainly giving us enough food for thought as we move into our next discussion around some action that we could collectively and individually be doing over the next couple of years. But before we move there, I do want to give everyone an opportunity just to pause and raise some questions if you've got any for our three speakers. And so what I'm going to do is I'm going to focus on our three different audiences and give them an opportunity to share some of their comments and their questions, and then we'll direct it accordingly to the speakers, and just so that we can ensure both an audio and visual response to the questions. I am going to ask the speakers to come up to the front when a question is directed, or when you feel that you're going to add some comments and some input to that area. I also want to note, just before we move into the Q&A section, that we do have Ashley over in our, for those of you on the phone and perhaps visually can't see Ashley, but we have someone who's taking notes for us today. And it is difficult, particularly I think in this kind of a setup with the kind of technology that we're using, to ensure that everyone's questions gets raised. So if you are raising questions either using live stream and Twitter or the chat feature there within that, or through the webinar platform and using that chat feature, if we do not get to your questions, please note that they will will be recorded, and we will make an effort to answer those questions and feed that back as part of our wrap-up report and follow-up information that we'll be sharing with all of the participants. So we'll do our best to get most of your questions answered, but we have about 10 or 15 minutes for questions, and then we're going to move into that larger discussion. So I think I'm going to start first with those of you who are participating through the webinar platform through Adobe, and I'm looking at Sarah, who's monitoring that, and there are no questions? Okay. I will also perhaps just give it an opportunity for those of you who are participating in that feature in that way to I'm going to ask that the phones be unmuted for a moment so that if you do have an opportunity or a question is sort of front and center and you didn't have a chance to share it on the chat feature, that we can do that now. So if you bear with us just for a moment, we're going to unmute the phone.
All participants have been unmuted.
Okay.
We will now rejoin the conference.
So if you're on the phone and you do have a question or a comment in relation to our presenters' discussions and topics, please feel free to raise those with us now. I'm going to give just a minute, and then I'm going to do that typical teleconference piece where silence is, you know, that there is either agreement or there are no questions. Okay, perfect. So we're going to put the phone back on mute. Thank you. So then we're going to turn to those of you who are participating via live stream. And I know Melissa's still playing with the phone right now for us, dealing with that. But are there some comments or questions via Twitter? No.
And Twitter, let me just check. No.
Okay, so now I'm going to open it up to those of you who are in the room. Are any comments or questions for any of our speakers? And there is one way in the back. So I'm going to just have you raise your question, and then I will likely just repeat that so that those on the phone and watching live can hear as well.
Sure. So I work with Central Toronto Community Health Centres, and a lot of the folks we work with are living in poverty or homeless or street involved, and so high-risk consumption of alcohol is you know, the real issue in our community. So I'm interested in hearing what the speakers' responses are to harm reduction initiatives that could be used on a community-based level, and one that comes to mind is the Seton House Annex program and using that model in a community-based setting. So I'd be interested to hear a little more about that, as well as addressing the use of non-potable alcohol.
Sorry,
potable alcohol, like Listerine and rubbing alcohol.
Okay. So our participant had two key questions, and I'm going to try and sum those up. One was just interested in our presenter's perspective on harm reduction strategies at a community-based level, what can be done, and also sort of the non-portable alcohol. Non-portable alcohol.
Alcohol,
right. Rubbing alcohol, etc. So I don't know. I'm going to open it up to our speakers to see if any of them have some comments to make to either of those questions. Any comments? So I'm going to ask that you come up just so that, again, it gets recorded. Thanks, David.
In the area of harm reduction, it is one of the pillars of the Toronto drug strategy, and for alcohol, as with illicit drugs, there are important interventions that can be made. So, as the speaker mentioned, there is a harm reduction program for people with established alcohol use problems, so that when they come into the shelter system in the City of Toronto, they can do so without risking withdrawal from alcohol and so forth. So I think that's important. I think it's important to separate harm reduction as a stream of interventions which help reduce the harm for that segment of the population that already has a very serious problem from the broader prevention efforts on the prevention pillar, which has been the subject of most of the discussion here today, and most of the three presentations are really focusing on more upstream prevention. When it comes to non-potable alcohol, Susan reminded me that we have, through the drug strategy, organized some discussions of non-potable alcohol issues in the City of Toronto to raise awareness and start to look for solutions. So it is a concern, again, for a segment of the population that usually already have quite a serious problem. So our work in that area has mostly been around awareness raising and sort of making people aware of the problem.
And using a harm reduction.
Yeah. Thank you.
Sorry, I just want to add one more piece before you leave the podium. Do you see the city supporting community-based agencies in a non-shelter setting being able to use harm reduction initiatives such as the Seton House Annex program? So having, you know, alcohol available within a harm reduction program in a CHC setting.
Yeah.
David, could you just summarize that so that those on the phone and live could hear that?
The question was whether the City of Toronto as a local government would support other community agencies to deliver harm reduction services for alcohol, including things like the program at a city shelter that involves allowing people access to alcohol while they're in the shelter. Well, we certainly do that for other harm reduction programs. We work very closely to implement our harm reduction programs for illicit drugs with a range of different agencies. So the model exists. You haven't used it for alcohol. And it's a question, it's an issue that I frankly haven't come to grips with yet, so something we might want to talk about.
So there is one more question in the room, and then I believe we have one question via Ustream. So yes, question in the room.
Yes, you haven't addressed up front the problem of prenatal, postnatal, and early childhood prevention of alcohol harm. And I, having been around the block many times, remember the beginnings of the Non-Smokers' Rights Association, which spent a lot of time alerting people to the harm to children who had no choice. And I'm wondering why we haven't addressed that more, especially with the existence of fetal alcohol syndrome and various other things, and the predisposition of some children of alcoholics to alcoholism themselves. It seems to be slightly genetic. Are we going to, or do we not have enough data yet to proceed on that? Okay,
good question. So just to sum, the question was really asking, are we going to be looking at, because it doesn't appear that, at least certainly not to date, in this session that we've talked about issues related to prenatal, postnatal, and early child development and the associated risks and harm between alcohol use and that area. So again, I'm going to just open it up to one of our speakers.
Thank you. I'll take a first stab at it. I think it's a very important issue. I think we have data as far as I understand, but we don't have as good data as we could. And in some cases, what's been done is they've taken the U.S. data and divided by 10 or by 11 because the population of U.S. is 11 times that of Canada, which is not very adequate. But I think there's efforts to gather more data on this issue. It fits into the larger category, and Ashley Wethofer, my colleague, and I, and others are hoping to get a proposal funded, which is called Harm to Others from Alcohol. And what you've talked about is really on that issue. What is a range of harm from alcohol beyond the harm to myself if I'm a heavy drinker? You know, how is my family impacted? How is my workplace impacted? How are innocent people impacted? How are the unborn children, and so on and so forth. So I think it's a very big issue, and it can drive an agenda forward, and it needs more attention.
Have you done anything on the full cost accounting issue that I noticed you mentioned in your presentation?
There's work going on that, and there are some initiatives done by CCSA, and the estimates are that basically the cost from alcohol is larger than the revenue.
Well, we knew that.
Did any of the other presenters want to comment on that issue? Okay, I believe we've had a question or a query come in.
What about research around non-palatable alcohol consumption?
So research around non-palatable alcohol consumption. There's a query about that, so does someone want to respond? Norm?
If I give some bad answers, maybe I won't be less popular, right? I don't know the area at all. I think it's an interesting question. I'm not sure. Is there any way of finding out what the listeners has? Do they want me to put toxic stuff in addition to the ethanol into the alcohol, or what?
We'll see. It might just take a couple of minutes to.
Okay.
For someone to reply.
I think, as you can tell, I don't really know how to answer the question. I think the real intention of the producers is to make the alcohol as palatable as possible, rather than go the other direction. This coolers is a way of making alcohol more palatable. Obviously, coolers are less harsh to a naive drinker than straight shots and so on and so forth. So I think it really would be counter to the general direction of what the industry is going to.
Is it possible that maybe they meant non-potable? Yes.
I think so.
Oh, that's a very important issue, and it relates to the previous comment that that is a real concern. That people who use alcohol that is not conventional alcohol. It does cause a lot of damage, and also does cause death. And I think it's an important issue with regard to youth as well. There's always a few stories each year, and they're not stories, they're anecdotes of real life situations where people have found something that they thought was potable alcohol was something else, did contain ethanol or did contain methanol, and so on and so forth, and either severely damage themselves or cause death. So yes, it's an important issue, but I'm not an expert on that area of research.
Oh, and I have a bit of clarification from Elizabeth relating to the increased cost. If we increase the costs of what's sold at the LCBO, it may result in more people resorting to Listerine, drinking, and that kind of thing. So
that you would have to, I think, increase the cost by a very large amount. Most of the studies that I know of do not have that side effect, and that the net benefits from increasing the costs, the overall benefits are larger than possible side effects.
Okay, we have one more question in the room. Oh, so two more questions. Great.
This question is for Norm, just because you're on a roll. On your slide about challenges and public misconceptions, you put that policies are designed to reduce harm, not prohibit alcohol. And I just didn't quite understand. Do you think that the public thinks you're trying to prohibit alcohol? Or do you think the public thinks you're trying to reduce harm?
Okay, and the question really had to do with clarification around Norm's comment on one of his slides in relation to policy looking to reduce harm, not necessarily prohibit. So I'll leave it to Norm to clarify.
I think that often the response is when policies are proposed is that, well, that's just a nanny state, and or you're just trying to take you're penalizing the people who do not have the problems. And that's to me a myth, because if the price of alcohol goes up by a small amount, and if I drink 9 drinks a week, I mean, it would be less than half a slice of pizza, to pay that difference. It really is not a burden to me as a light drinker, but it will be more of a burden to the more you drink. So the policies are justified on that basis. They create more of an impediment to those people who are higher at risk than those people who are moderate drinkers. But there's often the message by the media that these policies are prohibitionists. They're not prohibitionists. You cannot point to any policy that Dr. Madsen presented, or I presented, or Dr. McKeown presented that stated we want to prohibit alcohol. They do not prohibit alcohol, they control alcohol.
Oh, I had a question. It's also for Norman.
Okay, another question for Norm. Norm, could you just maybe repeat the question?
Hi, thanks for the great presentations. My question, Norm, is you had mentioned that there is a huge range of research that's now influencing policy around drinking and driving countermeasures, in part because of the political focus in that area. And I'm wondering if there are other areas that you think are maybe weaker that we should be focusing our research and policy efforts in terms of the range of policy measures we would want. Like, where is there another key area of focus that's kind of that we should be looking at? I know they're all important.
Should I repeat that?
Yeah, just summarize.
Are there any other areas of research where we need more evidence with regard to policy? I wouldn't say policy per se, but I would say areas where there need more evidence. We need more evidence about the closing of the gender gap with regard to males and females. That's a big area of concern. I think we need to promote my own agenda, if I could be so blatant and so un-Canadian. You need to look at how alcohol is harming others than the drinker. There's not very much evidence beyond drinking and driving. Drinking and driving, there's lots of evidence, but in those other areas it needs more work, such as FASD and so on and so forth. And last but not least, I think we need to do a much better job of tracking in a more granular and refined way the impact of marketing, advertising, sponsorship, and promotion, and what it is and how it's impacting, the beverage choices, the beverage levels, the beverage drinking, especially youth and young adults, and Dawson Johnson has talked about the marketing, the pinking of alcohol, if you will, and how that's very much oriented to young women, and how that's impacted their drinking. So these are three off the top of my head.
Okay, we're going to take time for just one more question that we have online.
Yes. So one of the users here would like to know more about screening tools for hazardous drinking used by health professionals, for example, CAGE tools. Is there consistency in the use of screening and brief intervention tools across the province, and in what settings?
Okay, so the question really had to do with more information on some screening tools and some brief intervention tools. So is there one of our speakers who would like to respond to that question? Norm? Thank you.
Well, I was hoping there's very, as I think Dr. Madsen said in her presentation, there's very good evidence that screening and brief intervention, there's been many controlled trials where they've given people, a screening and brief intervention, and given them just straight counseling, or just give them an information package, and they found it has an impact, 6 months, 12 months later in terms of their drinking. There's a whole range of tools, and I think there recently was a release from the College of Physicians of Canada. What's it, Marion? You have that.
The College of Family Physicians of Canada,
right,
along with CCSA,
right,
have released the alcohol screening, brief intervention, and referral,
right,
clinical guide online.
Okay, the College of Family Physicians in Canada, along with the Canadian Centre on Substance Abuse, have released a guide. And so I think if you go to the CCSA website, you'll be able to find that guide, and that would be a very good place to start. Dr. Peter Butt from University of Saskatchewan, I believe, is a leader of that initiative, along with others, and that would be a great resource. But there's a whole range of tools that can be found at CAMH. Dr. John Cunningham has initiated a lot of initiatives involving self-guided, if you will. So you can go online and put in your gender, your age, your weight, your drinking patterns, and so on and so forth, and then have tools in terms of how to reduce your alcohol consumption.
Okay. So thank you. Again, just for those of you who are participating virtually, if you have a question or a comment that we did not get to, please share it via your Twitter or a chat room, and we'll make sure that we address it as part of our wrap-up and our debrief that we will be moving forward with. So the next part of our discussion, we've got about just under a half an hour. And what I'd like to do is really open it up to have a discussion about moving forward. I think our speakers did an excellent job of outlining some evidence, talking about where we do see action that's based on evidence, and also outlining where there perhaps are some gaps. Or I'm going to borrow Heather's phrase about strengthening and maintaining, so that there is, we minimize the slippage that seems to be underway in a couple of areas. And David did a fabulous job of looking at, so what are those local initiatives that we need to be doing concurrently with some of the provincial efforts and national efforts that are called for as well. So we've got 3 questions, and they're big questions, and we realize that they're big questions, but I think they warrant a conversation. So what we would like to do is really open it up to our participants to see whether or not, given the range of information and issues that have been surfaced this morning, what you would like to see, what you see are some of the main action steps needed in the next couple of years. So a small window. What do we need to be doing in the next couple of years? And if you can, when you think about that, really start to think about, government for the Ontario Chronic Disease Prevention Alliance as a provincial alliance that represents a range of organizations for research and for organizations individually, and then also start to think about those challenges and how we can minimize and impede those. So those are fairly fluid questions. So rather than look at them one by one, I really would just like to open it up now for a conversation. What I'm going to try and do is similar what we did with our question and answers. We'll go to the virtual participants, give them an opportunity to share their comments, their thoughts. We will be recording all of this, so although we don't have a vehicle right now to show the kind of range of ideas that are surfacing through our discussion, they will be recorded, and then they're going to be shared back. So this is the other interesting thing I do want you to keep in mind. Because if you're like me, I'm a reflective thinker, so I'm not necessarily at my prime in sort of the brainstorming. I like to process and digest. So what we are going to be doing is we're going to be releasing a draft sort of summary of today, summary of the key points that the presenters made, summary of our discussion. We're going to be sharing that with all of the participants. And you will have an opportunity to continue to add some thoughts, particularly around these discussion questions. And these discussion questions will also be a part of the evaluation that you'll be receiving electronically. So the discussion's not going to end at noon, and you will have an opportunity to continue to shape the kind of actions that are identified. So with that fairly long-winded introduction to this section of the agenda, I'm going to look to Sarah, who's monitoring the webinar platform, and at this point there's nothing that's come up with the chat room. Could we open up the lines on the telephone just to see whether or not there are some participants that just want to talk versus share their thoughts on the chat room?
All participants have been unmuted. You will now rejoin the conference.
So again, for those of you on the phone, this is your opportunity just to make a comment, to think about these questions and share your thoughts and your perspectives. Anyone? Okay, I think what we'll do is we'll put the mute back on, but again, feel free to indicate to Sarah via the chat room if you have a comment or an observation that you'd like to make and share with us. Thanks, Melissa. And now for those of you who are participating live stream and sharing your thoughts and comments via Twitter, any reaction to these 3 questions, things that we want to be thinking about as we're looking to make some decisions for the next couple of years? Okay, well, then I'm going to turn it over for now to those of you in the room. And I am going to ask perhaps, rather than having me summarize your comments, it gets a little bit more complicated, I think, in this part of the agenda. I am going to encourage you to come as close to the front as you feel comfortable, preferably all the way to the front, so that we can ensure that those that are participating virtually have an opportunity to benefit from your comments as well. So thinking about the next steps, what should we be focusing on in the next 1 to 2 years? Heather and Norm in particular outlined some really important areas, and as much as we like to say we're going to do it all, I'm not sure that we can. So, based on those comments and work that you're doing, what are your recommendations? What are your thoughts? So there's someone at the back. Can I please ask you to come forward? Thank you. All the way before you talk, just so that our virtual participants can benefit.
The obvious thing to me is just the dissemination of the guidelines, because even people with nutrition background probably don't know what is a good daily amount. And just even for the prenatal thing, right on the guidelines on the second page, there's a list of people who should have 0, and pregnant women are in that. If they're widely disseminated at an OB's office and they look at that, oh, I don't have 0, maybe I do need help. Even that in itself would approach with all of that. So just curious, because you said we're starting off at things like wine shows and this and that. At what point will it be disseminated to doctors' offices?
Yeah. So good point. That's really looking at making an effort to widely disseminate the low-risk drinking guidelines. David, yes.
I was struck with Norman's comments about the richness of the evidence base when it comes to drinking and driving. And looking at all of the evidence across all the different interventions, that was one area that there seemed to have been a great deal of work done. And I think we should look at that to see what lessons we can learn from the efforts in that area. I think it is an area, relatively speaking, of success. We've seen certainly more controls, more regulation over time. It's an area where the outcomes have improved. We've certainly seen a reduction in mortality from motor vehicle accidents across North America, and that's not only to do with drinking and driving, but I think it's partly accounted for by that. It's also an area where we've seen a real change in social norms, and that's kind of the holy grail for any health behavior, is a change in social norms. So you go from handing somebody a drink as they go out the door after the party, one for the road, to taking away their keys. That's a change which has happened over a long period of time, but it's a very, very big change. All you have to do is watch episodes of Mad Men and get a sense for what's happened in the past 50 years. So what did we do right when it came to drinking and driving, and what lessons could be applied to other areas of alcohol policy? One thing, I think, is that it was a very humanized approach. We really talked about the human cost of drinking and driving in a very explicit way. Another feature would be that it wasn't just about health professionals talking about it. There was a very strong non-governmental organization effort through Mothers Against Drunk Driving and others to advocate. So I think that's an area that we could look at for lessons for other areas of alcohol control.
Thanks. Any other comments, input? Heather? And then I think we've got another one at the back of the room.
Thank you. So I wanted to pick up on your idea about communicating the new low-risk alcohol drinking guidelines, and just refer to a project that we have underway at Public Health Ontario, working with Ben and others in our group, where we're looking at the evidence on what are the best ways to communicate the new low-risk drinking guidelines, and particularly considering various subpopulations who may be at special or higher risk. So I think that'll be quite an important piece of work that is underway and that we're hoping to share just generally. I know for myself, I'm quite interested in this whole aspect of the pinking of alcohol with the increasing consumption by women, and particularly some of the things that are going on in the younger population. You mentioned, one of you guys mentioned pre-drinking, this sort of alchorexia behaviors, some really unusual and interesting things happening on campus I think we need to get a handle on, happening with the young adult group. So I think there are a number of interesting, for me, research questions that we need to address, and I think there's a need to kind of prioritize what those research questions are, because there are in fact so many areas that could be picked off. But I think that particularly looking at social marketing, or how do we communicate the new low-risk drinking guidelines, what are the particular messages? The zero consumption message to women considering pregnancy, women who are pregnant, the zero consumption, the link between alcohol, the sort of the no lower limit for alcohol and cancer risk. So I think that's going to be a very, very rich area for exploration, looking at the evidence and then communicating that evidence and implementation.
And there was another, thank you Heather, question or comment at the back. So again, if you're comfortable coming up to the podium, please feel free, or at least come up so that we can capture your voice. Thanks.
I'm Patrick Ford. I'm from the LCBO, and I just want to comment a little bit further on the distribution of low-risk drinking guidelines. And this gets back to David's point a little bit about going into the belly of the beast, maybe as well too, relative to the Food and Wine Show. We distributed 500,000 copies of it this summer with the circulation of one of our issues of Food and Drink magazine, which to our knowledge is the biggest distribution that's faced, whether national or in the previous provincial guidelines as well too. They're available in all of our stores, 600 plus stores across the province. And we've also made public health offices across the province aware of our willingness to share and produce whatever quantities are required. Uptake on that isn't, I guess, quite what we would hope for that, and I suspect it's in part because we're the source for distributing the copies of the guidelines itself. But I just wanted to put that plug out there that we are very keen on ensuring that the guidelines get as broad and as thorough a distribution as they can. So thanks.
And I noticed that there is a comment or a question on the webinar platform. So Sarah, could you just share that with us?
Sure. So we have two comments. First is that we need to address advertising, including on social media. And the second comment is that we require or need to address the need for mandatory labeling to include number of standard drinks as well. And then we have a question. What action or progress is being made on a provincial alcohol strategy?
Okay, so just to repeat, 2 areas for action were suggested. One was looking at advertising and social marketing, social media. Was it social media or social marketing?
Social media.
Okay, that's what happens when I take shorthand. And then the other was looking at mandatory labeling in terms of the number of standard drinks. And then there was a question around action provincially on a strategy, an alcohol strategy. And again, so I'm going to just ask if there is one of our speakers who really want to talk about what action is currently in process to help initiate that or build some momentum for that. Anyone willing to respond? Norm? Our man of the hour.
All I'm going to say is that the series that Ben Rempel has organized for a number of years now, the Alcohol Ordinance Commodity, in the last 3 years at least, there has been a very strong message from the attendees. 190 to 100 attendees say that we need a provincial strategy. So I think that there's some real groundswell of support for that idea.
So I just wanted to make a couple comments. First of all, Public Health Ontario, we're arm's length from government. We provide scientific and technical advice and support. So we're not the government. We don't create the strategies. Having said that, one of the things I wanted to mention is that there is the National Alcohol Strategy, and so we can look to that for what are the key elements, and there's 4 pillars to that strategy, and there's something like 41 recommendations within that strategy. So it is possible to look at that and map what is Ontario doing in each of those domains. I think I'll leave it at that. Thanks.
Any other comments and thoughts in the room about some of these, identifying some action steps and what we need to be doing to move forward? Yes, excellent.
We haven't really addressed the whole business of the abolition of advertising alcohol. It took us a long time to prevent the advertising of tobacco, but it finally worked. And I would think there's a sort of a roadmap there for us to look at the alcohol thing. I have the What's in for Spring LCBO book. I have apoplexy every time one of these things appears in my weekend paper. And it's taught as the style setters, and it looks at high-heeled shoes, it looks at an attractive young man and a few drinks. And at the back, the Cosmo makeover, and it has an anorexic-looking girl called Skinny Girl, white cranberry Cosmo, all pink and white. And I'm afraid, I'm not able to use your temperate terminology. This is evil.
Okay.
It is absolutely wrong, and if we're going to try to attract women to the fact that drinking for them is particularly hazardous, if not for them, for their child or children, then we've got to get rid of this stuff, because this is very seductive in a group that is really subject to peer pressure. And that's what this is leaning on, and it has to stop.
So thank you for that very passionate and powerful
grandmother speaking
position. And again, just to some really a strong message and strong support that one of the key areas that we should be putting on our action steps for moving forward has to do with looking at abolishing advertising in relation to alcohol use. And I think we've got one more comment or a couple more comments in the room.
So I'll just, my name is Chris Markham, and the organization I represent is OFIA. So I think one of the other things that we need to put on the table is with respect to just ensuring that our kids are equipped to be able to handle the realities of a 21st century society, ensuring that they have the resiliency and the decision making and the life skills not only to be able to interpret a lot of the media and the messaging coming at them, but they also have the skills to be able to resist social pressures and to make healthy decisions for them. So I think an updated curriculum would help, and
good plug for the curriculum there, Chris. Thank you. And there's another comment in the room. Yeah.
Hi, good morning. I'm Nancy Graham. I'm a public health nurse for the City of Toronto. And I think there are a terrific opportunity to target high risk would be even the college and university population. I think it would be wonderful to collaborate with public health units across Ontario and maybe look at best practices for working with post-secondary population and focusing on young women and the pre-drinking, binge drinking, and working with peer leadership groups. I know we are doing that with some of the colleges and universities here in Toronto, but I'd like to know about the development of maybe best practices and some research in that area. I think would be a fabulous opportunity.
Great. So just to repeat, and then I believe Heather has a comment. There really was a push for us to look at some research around best practices and how we could be looking at high school, particularly post-secondary, high-risk drinking populations and also women. And I think with that, I'll turn it over to Heather.
Yeah, so I mentioned Ann Dowsett-Johnson, who did the series in the Star last year. I met with Ann recently, and she is very interested in this particular issue as well. So she focused on alcohol in women last year. She's also then now focusing more on alcohol use on campus. And again, I want to echo the idea of working with peer leaders the way we have done in tobacco control on campus. And I think there's a wonderful opportunity for exploring what are the alcohol policies on, there's a research opportunity here too, really. So I'll go to questions. What are the alcohol policies on campus? How do they differ across various provinces, across various campuses? What's the culture of alcohol use on campus? What are the aspects of that culture that facilitate or promote alcohol use compared to? And if we think back just anecdotally what we've seen in the paper, immediately there comes to mind certain aspects of campus life that really create a culture, or lean towards a culture of acceptance and more social pressure, in fact, around alcohol use. So what are the policies? What's the culture like? How do students respond to that culture? What are some of the new drinking behaviors that are emerging on campus? And then how do we use the lessons that we have from people like Kellyanne Lawrence in tobacco control about leave the pack behind? How do we use peer leadership to create a social change on campus? To create a more healthy alcohol use environment. I think it's a big opportunity.
Okay, we've got just a couple of minutes, so I don't want to curtail what is a really engaging conversation, and so I'm going to look to Norm, and then I believe we've got something online as well.
Thanks. I just wanted to make a recommendation, or maybe it's a challenge to NGOs under D here. I think the major NGOs that deal with chronic disease need to pay more attention to alcohol. I think the Canadian Cancer Society, the Heart and Stroke, and other organizations, they need to pay more attention to it. Not to take attention from other things, but they need to train the staff to pay attention to this issue, and I think there's also, in some cases, there's a bit of a mixed thing with alcohol. In some of the events, such as the marathons or runs, you will find there be free alcohol at the end of it. This is a contradiction, quite frankly, to be promoting health, to try to reduce cancer, to reduce health, and then to have free alcohol at the end of the run. I think those are, you need to be arm's length with regard to those things, and I would put that forth as a challenge.
Okay, so one more comment from online.
Yes, this is from a health unit, And they say, we would appreciate resources, either print media, display from a provincial agency level to support our local work for consistency in messaging.
Okay, so that was really an action step around collecting and making available resources at a provincial level to really ensure and support that consistent messaging from one end of the province to the other. Okay. Any other, I'm just going to look to the room now, any other sort of closing comments, urgent action items that you feel passionate about that you want to just share with us before we wrap up? No? Okay, well, we've kept to our time quite nicely, so thank you for that. And I do want to just thank both our wonderful caliber of panelists for their clear and insightful and thoughtful and I'm going to say provoking presentations, because for me what it really did was tie very nicely back to our topic for today, and really helping us sort of look at evidence and action, and where there are clear pockets of evidence and no action, and also highlight those areas where yes, we are making some difference, but perhaps we need to just continue to put some energy to sustain and maintain those areas as well. And the other messages that I heard repeatedly today as well were that there are some clear gaps. Certainly the issue around the low-risk drinking guidelines came forward. Issues around public perception and advertising just seem to resonate in all of the presentations and the conversations thereafter. As well as that need for a provincial strategy and learning, taking time to learn from tobacco, to learn from those policy areas where there has been impact. So I think clearly we've got some research agenda items to consider and to think about. So thank you so much for your conversations, for your input, for your attention, and particularly I want to thank those that are participating virtually. And just a reminder in terms of sort of some next steps, please stay connected with us. We do have this recording that will be online, and so certainly encourage others to come and check out and participate that way in the discussion. We will be sharing, as I said, a summary of today's notes and giving you an opportunity to continue to contribute to our thoughts about moving forward in those action items that are necessary. And that will be coming forward in the next couple of days, along with an opportunity to give us some feedback on your thoughts from this session this morning. We also have Dialogue, our newsletter that will be forthcoming in the next couple of weeks, and the next edition will have a strong focus on high-risk alcohol consumption and connected with this morning's event. And certainly we encourage you to participate in the series as it continues to unfold in 2013. And a reminder that late spring we will be looking at a summative event which will try and pull some of the thoughts and some of the recommendations and action steps forward that cut across all of those risk factor areas and really start to build on what we could be doing. And John, do you have a comment or a question?
I was wondering if you could mention the date of the next session.
Yes, I could, if you could remind me of the date. Is it the 29th?
January 30th.
30th, I was close. So the next event is looking at tobacco, and that is January 30th. And that is available. There is information online on our website, and there will be some more details to follow as well. So thanks for that reminder, John. And I think with no further ado, I'm going to just repeat a thanks to our co-hosts today, Public Health Ontario and the Centre for Addiction and Mental Health. And if you haven't had a chance to check in on for those of you participating in person, we do have a participants list out front, and so if you haven't had a chance to check in, please do so. It just is helpful for us to have a good sense of who was in the room. And with that, I wish you all a good afternoon, and thank you so much for participating.